it's quite crowded, so thanks for coming here. I'm Alexander Vlaar. I'm an ICU physician from Amsterdam. These are my conflicts of interest, which of course are specific also for this talk important. When you are facing in your clinical care setting an event, what you are normally doing is that you wait till the event occurs and then you start to act. You can start with medication, resuscitation, fluids. But actually, when the event there is, you cannot much do than just pull everything what you have, like fluids, inotropes, vasopressors. So it's reacting instead of proactive handling. So actually, the actual event in your body, physiology, is already starting much earlier, but our physiology is so smart that we try to compensate with maybe increasing heart rate a little bit that you might be able to see, but there are also other compensative mechanisms which will keep this blood pressure high until it crashes. So actually here's already a window of opportunity, but we just are not able to get it clear to us. So what we would like to be able to have this early. So maybe there's an actual bleeding, this blood pressure will stay high because it's somebody who can compensate, then you get the clinical awareness, and you would like actually to be, before that, preemptive to do an intervention. And then, of course, resuscitate the patient again. And to do that, you need to have insight, of course, that the event is occurring, and if it's occurring, you would like to be able to intervene in the cardiac output, the arterial system and arterial pressure to be able to intervene in the right setting. So to modulate the metabolic demands, to regulate, compensate cardiac output changes, but also to keep constant perfusion pressure. So a machine learning derived algorithm, the HPI in this setting, it predicts the occurrence of an hypotensive event coming. You see here on the top, you see the number. It is a number which, when it's going above 75, 85, it has a very high specificity, but also sensitivity to predict an event occurring. You have a secondary screen where you can have like a diagnostic. What is going on with my patient and where it may benefit from. The only thing is, in a way, it's looking into the future because something will occur. So it can be that it's not always already stating actually what will be happening in the future. The only thing is, something will happen. So how was it developed? Because for most people, when we talk about machine learning, it's like a spooky black box and like what is happening there. Well, so how was it done? It's a huge database of ICU patients and OR, in which, out of the waveform, features were taken. So here you see a waveform where features can be taken out. Up till 2,600,000 features were taken out of it, of such a waveform. So you understand that just by your eye, understanding so many features, you will never be able to do. So you cannot compete that. And out of those features, there were something like 20, 30 features which were really prognostic for an hypotensive event. Some of them we understand from a physiological perspective, but some of them we do not understand, but they are highly predictive. So when you do a data training, you get the model. Very important to do an internal validation, an external validation, and in the end, of course, also a randomized trial to show that a machine learning derived algorithm is really helping your patient, because building a model is not is possible for a lot of people, but really showing that your model is going to improve patient outcome, that's important. So what do we define as hypertension? That is a blood pressure of 65 millimeters mercury below for at least 1 minute. So, and again, what I was saying, 2.6 million features were put in the analysis, and in the end, 23 features which were really highly predictive. And this is the ROC curve. So you see a very high sensitivity, high specificity to predict. And you can do that 5 minutes, 10 minutes, or 15 minutes before the patient occurs. What you see here is very interesting, that any other factors, such as MAP, because a lot of people say, Well, I see this patient is already falling down. I can see it from the map. You see here, if you take map, you just can flip a coin whether a patient becomes hypertensive or not. You cannot know from the map whether a patient in the future will become hypertensive. So it is really adding value on top of the features we now have and use in clinical setting. So the performance of the HPI has been tested in several sites. So not in one site, several sites. So here you see it is confirmative in patients with cardiac surgery, a retrospective analysis in non-cardiac surgery patients showing the same things. Not only on invasive arterial measurements, but also non-invasive. With a cuff, we can also measure beat to beat blood pressure, and the HPI works as well there. So what we did an external validation in the OR setting, and in this setting we published in European Journal of Anesthesiology, we showed it had a beautiful performance. And what I was mentioning, the really proof is doing a randomized trial. So this we published a few years ago in JAMA, in which we randomized patients being treated using the algorithm versus just standard of care. And what you see here is the primary endpoint is time-weighted average, which means you're correct for depth and duration of hypertension. Because we know that both of them are associated with poor outcome, the longer the hypertensive event is and the deeper. So you want to have a universal measurement for defining the severity of hypertension. Of course, in your clinical practice, you will not use TWA, but it's important to be able to really compare the groups regarding the severity of hypertension, but also in the future to compare other trials. So we really like in hemodynamic research to use TWA instead of just hypertension incidence of or other forms. But of course, for a clinician, because sometimes that's more easy, you see also that the incidence, the total time, everything is significantly reduced by using such an algorithm. So it's an early predictor of arterial hypertension. And here again, you see the index. Here you see the secondary screen in which you can see the underlying mechanism of hemodynamic instability and which will be able to support you what is going on in your patient. So some of the classical things you know, stroke volume variation, cardiac output, stroke volume, vascular resistance, but DPDT maybe is new for some of you, or dynamic elastance might also be new for you. And this is additional information which really helps to optimize the treatment of your patient. So stroke volume variation and dynamic index of preload, arterial DPDT max, left ventricular contractility, and dynamic elastance is a dynamic index of afterload, so pressure responsiveness. And in that way, it really helps to decide you, should I get...
How did you calculate the
DPDT, I will get to that. Very good question. Stay there and you'll get the answer. So this combination of those three factors is very important to look at. So whether we need to give fluid administration or inotropes to increase ventricular outflow, or use vasopressors to increase arterial tone. So how should we manage? And now I'm coming back also to your question later on, to the three factors. So stroke volume variation, it is an balance between your cardiac preload and your stroke volume. And together with your pulse pressure variation is a very important factor to understand whether your patient may benefit from fluids. If we look at the DPDT, and this is your question, there we have the time in your arterial waveform and the pressure. So delta pressure divided by the time it takes to get to this maximum. You got it? So, and here you see on the left a patient on dobutamine, which is of course inotrope. So you will get a better DPDT, which means your pressure will go higher in a shorter time frame. In a way, from your waveform, you're looking into, when your aortic valve is open, you're looking in your left ventricle. So in that way, you have a measure of how strong is your ventricle contracting. So if you would put a beta blocker on it, esmolol, it will go slower, so more time for the contractility, but also less strong, so you get a lower DPDT. Yeah?
Is it then calculated the pressure waveform?
Yeah, it's calculated.
Don't have
No, so it's not an intracardiac measure, but it's from outside. From outside looking inside.
Is it the same as the one calculated via the ultrasound?
It's a bit different because in the end it's from outside, but and that's, I think, a very important thing also. It are not in the end the absolute values which count in this setting, it are the trends. And I think that's also, of course, an issue in discussion often. This is a non-thermodiluted, non-validated way of monitoring. It is doing fine, but to have the absolute values, you might need to do Zwangans or thermodilution, or you need to do ultrasounds. But in the end, what really works, and we showed it also in the trials, is that it's helping you in the trend analysis. And the trend analysis is actually saying much more than this absolute value. Because also with the thermodilution, we know it is not absolute. And also with your ultrasound, I mean, its intraoperative variability is quite high. So we believe really that this trend and also monitoring the effect of your intervention is much more important than this absolute value. Yeah? Then dynamic arterial elastance. This is a combination also between stroke volume and arterial pressure, in which you have your stroke volume variation and your pulse pressure variation. And the dynamic elastance is dividing your pulse pressure variation through your stroke volume variation, because your arterial tone and the vascular resistance is not taking everything into account, which is really determining whether your patient will need fluids or vasopressors. So it's really helping you in differentiating whether your patient will benefit or not from vasopressors. So if it's low, your patient will benefit from vasopressors. If it's high, above 0.9, 1.0, it will benefit from fluids. So here you see it's very high with a high pulse pressure variation, with a low stroke volume variation. This patient will benefit from a fluid intervention. And here it will benefit from a vasopressor intervention. So with the same stroke volume variation in the previous, with a high pulse pressure variation, a fluid addition will help. So a low dyne or a high dyne, by dividing pulse pressure variation through stroke volume variation, is helping you to discriminate, next to, of course, the classic factors like vascular resistance, like stroke volume variation, to see where your patient is. So those three are very important. And in the end, what is important is that you make your own protocol, or you copy it from several being published. And what you see here is also, coming back to some of the questions, so what are the absolute values? You see in the protocols that we talk about increase or decrease or trends, and we do not talk about absolute values. So if there are more, so when do we start? When the HPI is going up, then we want already that you start looking, because something will be going on. Or if the map is already below 65, or the HPI is already above 85, then you should start treatment within 2 minutes. And that's also the thing what we're saying, you just should do something. You should act, because you know you get an alarm, something will be happening, but if you don't do anything with the alarm, of course, the hypertension will still occur. And this is also something what we see in the trials. There are some of the trials which are negative, but that's also, when you look very properly, the compliance rate with the alarms was very low. So physicians were not following up the alarm. And this is one of the things what you should do. And what we notice in our center, if people are not really believing it, then we just give them the device and tell to them, just start working with it, ignore it, but just look if the alarm goes up, whether there will be hypertension later on. And they always come back and say, oh, the algorithm was quite right. So, and that's the best learning to get used with it. So here you see it. So dynamic arterial elastance is decreasing, vascular resistance decrease, and stroke volume variation increase, then mostly vasoplegia. If there is an increase in dynamic, then it's probably hypovolemia. And if the stroke volume decreases, stroke volume and vascular resistance is equal, then probably contractility. And you evaluate, so there's a loop back. For example, if you give an inotrope, then you would like to see your DPDT improving. But there are several others. You can also start with stroke volume variation, then go to a dynamic elastance below 0.9, and then say you need vasopressors. So there are several ways to deal with this. And you can find them all online. So you can take a lot of pictures, of course, but if you just search for it, you will find them. So this is how it looks like, the screen. If this HPI goes up, here you see also the trends that you need to plan. So, and then you need to act. What, of course, the interesting thing is that some of the people, they say, but then we get more alarms. We will get fatigue of all the alarms. What we showed is actually by having this, it reduces a lot of alarms. Because all the time the blood pressure is going down below 65, the alarm goes. But with the HPI, you are able to prevent and predict and then be able to deal with it. The other thing is, what is an issue which is now and then noticed or mentioned, is that, oh no, but what you're doing is you're actually over-treating and you're just increasing the blood pressure, and in that way you're preventing hypertension. Well, that's not the case. In the randomized trial we did not see more fluids, we did not see more vasopressors, not more inotropes in the intervention group. The only thing what we saw, we gave it more often a little bit. So what we all know from medicine, if you prevent something, it is better than you need to cure something. And this is, I think, the practice we also know. If a patient crashes, then we give fluids, we give inotropes, we give vasopressors, because we think like, I don't know what's going on, but this patient is crashing and he needs to have everything, and you get an overshoot later on. So actually you're giving too much. And the good thing is here, because it's not yet occurring, you can start giving little interventions. The only crazy thing maybe is for the beginning, is you start doing interventions on something which is not yet there. And this is something you need to start learning and dealing with, but the trials show it really prevents your hypertension. So I would like to thank Ignacio also for working on all those slides and that we can use them also. I think we have now some real life also interactions. Or are there any questions for now? Yeah.
So in order to develop the HPI algorithm, you
Yeah.
take patients from the ICU and anesthesia.
Yeah.
Is it
Oh.
useful for ICU?
Here you go.
So in order, so
Yeah.
you took
Both populations, yeah.
patients, but did it work in the ICU?
Yeah. So we did we trained it, or Edwards trained it in an ICU and OR population. We did an external validation specific for the OR, and we did a specific validation in the ICU on another 500 patients, and it had the same ROC curve to predict an hypertensive event. Is that answer to your question?
Yes, but for patients that are in the ICU for days,
Yeah.
right? They get better. Say they were there for a septic shock, they got better,
Yeah.
and they got another ICU acquired infection.
Yeah.
Does it work? It's not the same patient that an OR patient, an anesthetic patient.
Yeah, but that doesn't matter. It's a physiological alarming system. It is alarming based that your physiology in your waveform is unstable. It's an instability predictor. And it doesn't matter whether you're in the OR, whether you're in the ICU, whether you're a septic, it is saying you are becoming unstable and you will have a hypertensive event. And that's why you need a secondary screen to start understanding what's going on. Can you follow it? Yeah, it's on.
Okay, it's working. Okay, my question is, when you get the alarm from the hypointensive index, have you also investigated what is the predictive power then of all the variables that you defined in your protocol, whether they really can predict the response of your patient? Because then you can already distinguish the non-responders from the responders and the fluid responders from the vasopressor responders.
Yeah, so what we know is that just the independent factors for predicting an hypertensive event, they are not good enough. So the HPI is really the distinguishing. What I showed, if you use MAP, although people always think that I can predict based on MAP that my patient will become hypertensive, you cannot. You can just flip a coin and it doesn't matter. So HPI is really important for that. Then the secondary screen, what I was mentioning in the beginning, it can be that the algorithm already predicts your patient becoming unstable, but actually in the secondary screen, you cannot yet see what is going to be the issue. And then what we always advise is to act, and often it is a vasopressor in the OR setting, which in a way is able to solve it for the short time being. And if then something else occurs, it can also be that you have a combination, but the important thing is that you need to do something.
Yeah, okay, so you didn't investigate the predictive power of those additional variables on the second screen when you have the alert? Because
We're
that
definitely
would
looking
be-
at that,
Okay.
and also how often indeed, and I think that's what you're mentioning, if it's saying vasoplegia, whether there was also really vasoplegia coming. Yeah, yeah. So we're investigating that. It will be probably a very high correlation, because else we would not be able to have a 70% reduction in hypertension. Yeah, yeah, yeah.
And the emergency patients, so patients in the actual ER, did you guys want to include them? Because this is where it probably would be most effective in the acute setting when you have patients who come in with acute trauma or acute medical conditions.
Yeah. So are there other areas of interest? Definitely. So, but that's more like in a machine learning approach. What we are interested in, can we predict already whether a patient will become septic, for example, in an emergency setting, or in need of vasopressors, because that would help a lot in distinguishing that you better can send a patient straight to the ICU instead of first sending to the ward, filling them up with 3 liters of fluids, and then after 4 hours you will be called by the attending physician that this patient is going bad. So we're working on that as well, whether we can distinguish already in this beginning which patient will need vasopressors. Okay? Then we continue, I think, Felicia. So we have here a first patient, patient just in your ICU, which I think is still stable. And I think we are just waiting to see the patient will still stay stable. So HPI you see here on top, it's now 58. Maybe we have a very stable patient, so we're treating it very well. So now you see HPI is coming up. So this is the moment, you see 87, where you would like to go to the secondary screen and to understand what is going on. So somebody who wants to say what is going on? Somebody. So it's acknowledged, yes, our HPI is up. We want to go to the secondary screen. So I was saying your map is still okay, so that's not going to help you. What you see behind here are trends. So your vascular resistance is a little bit low, but not that much. Stroke volume, but stroke volume variation is going up, 8%. Dynamic elastance is going up. So what do you think this patient needs? Fluids?
Yeah, maybe.
Yeah?
Not sure, yeah.
Yeah, but that's a good idea. That's a good idea. Maybe we can give some fluids. Patient in the meantime starts crashing also. So I think we need to do something, or we should already have done something. and the patient will recover. So now, of course, this is in a simulation setting. In the real setting, on average, you have 3.5 minutes before something is going to happen after the HPI goes up. So 3.5 minutes is quite a lot. You really have your time to take your medication. It depends, of course, on which level of HPI you already start acting, but you really have some time. All right, so we go to the next one. So HPI is very low, it's 10. It's going up a little bit, but normally this would not yet alarm you because sometimes it goes up, it goes down again. And now it's going really up. You look again at the trends. Although HPI will pop up, you really need to do something. You can already look at it. So who thinks what's going on now? Vasoplegia, why do you think that?
The afterload is down.
The
afterload is down.
Yeah? So you mean systemic vascular resistance?
Yes, and
Yeah, but more?
Dynamic arterial elastance.
Yes, that's very important in the discrimination. So stroke volume variation is going up. So when that's up, you can look at the dynamic elastance, and then you see it's low, and vasopressor might be the intervention. So let's see, Felicia, if we give some vasopressors. And what I was saying, after your intervention, you want to see whether it is also improving in your variables. HPI will go down. Your stroke volume variation will improve. Your dynamic elastance is improving. And HPI is going down again. So for the time, I think we need to go to the final one. It's just for giving you some sense, some feeling with how it works. So very important to stress again, the machine learning derived algorithm is very important to trigger you, to alarm you. But if you do not act on an alarm, it will not help you. So you need to do something, you need to act when the alarm goes off. So HPI is going up again. Who thinks, sees, wants to describe what you see? Yes, very good. So your DPDT is really going down. Contractility is really the issue here. And we could give an inotrope and we'll see what's going on. And in that way, it's a very simple approach, discriminating in the preload, contractility, afterload, and giving in a way also a personalized treatment to your patient. And although it maybe looks like, okay, I have to go through all those items, in the end, it reduces your alarms, your work, and it gives really insight into your patient, what's going on. So we are running at the moment, or we just finished it, also the randomized trial in an ICU setting. So hopefully soon I will be able to share the data with you, because we have the HYPE 1 already in JAMA, where we're really able to reduce hypertension in an OR setting, and hopefully next time to share with you the data how it's in the ICU setting. We already showed it works, the algorithm, it's validated, but now in a real life setting, if we give it to ICU physicians, to ICU nurses, are they able to do the same as what we have been seeing in the OR setting? Thank you very much. If you have any questions, also you can go to the booth, and if you want to see more hands-on with the